So there are two talks we're going to go over tonight. One is esophageal reflux disease. A lot of people know it as heartburn or Gerd. And the second half is going to be a little more about celiac disease, so two separate disease states. All right, so heartburn or esophageal reflux disease. Heartburn is actually the symptom. So the disorder is esophageal reflux disease. Many of you have probably experienced heartburn at least once in your life. About 19 million Americans get heartburn probably on a more regular basis. It's also pretty well known as that regurgitation you get. Some people call it agita, which is kind of that effortless bringing up of gastric contents into the mouth or into the esophagus. Sometimes people feel as if it's almost vomiting, but it's more of a regurgitation into the back of the throat. There are the unusual symptoms of esophageal reflux disease. One is what we call dysphagia, doctor's term for food getting stuck when you swallow. That food's just not going down right, it's going down very slowly, or in some people actually get stuck for a little while, and they actually have to pace around, drink some liquids, and fortunately it goes down, or sometimes they end up in the emergency room to see us. Throat clearing, that's a pretty common experience. Globus, that's our term for that feeling like something's in the back of your throat. It just doesn't feel like something didn't go down, but you're able to swallow without any problem. It's more of just a kind of a sensation that something's there. Laryngospasm, that's just difficulty breathing. Or we see a lot of dentists sending patients over with the complaint that their enamel is worn away on the back of their teeth, and the implication that acid coming up is wearing away that enamel. Probably reflux causes some of that, but probably less so than the dentist send it to us, though. Chest pain, unusual chest pains. We always want to make sure it's not a heart problem first, but the reflux commonly can cause chest pain. Hoarseness, a chronic cough, someone was mentioning to me that earlier. Sore throats and wheezing. Reflux generally occurs after eating, okay? Acid levels go up, food fills up your stomach, there's more pressure in the stomach, forcing food and its acid component into the esophagus. They're often triggered by large meals, bending over, stooping, or laying down, mostly because gravity's effect is lost, keeping food and acid in the stomach. Strenuous activities can cause reflux just because food is being pushed up and down, and gastric contents can flash up into the esophageal lining, and that causes discomfort. Reflux frequently related symptoms vary quite a bit from person to person. So this is the Gerd iceberg. So as a gastroenterologist, I kind of see the tip, the people who have kind of persistent symptoms that cause complications. The more frequent symptoms are often seen by the primary care physician, but there's a large component of people here below the surface who have the occasional symptoms. They don't see doctors, they get some Pepcid, some Zantac, maybe they get Prilosec and they treat themselves intermittently, or they try to avoid offending foods. Now half of patients with reflux will have erosive esophagitis based on certain studies, okay? So Barrett's esophagus, which we'll talk about later, is a complication from having long-standing reflux. And then there's another large percentage who really just have the sensation but don't get the damage. The severity of heartburn, or the symptom of reflux, it doesn't often correlate with how severe it is when we take a look in the esophagus. We call this erosive esophagitis. That's when the lining actually gets worn away and is irritated, sometimes can actually bleed. You can see here that people who describe severe symptoms, it looks pretty similar. All right, so having mild symptoms sometimes can actually, down here, these people barely, they said that symptoms weren't very frequent at all. But they actually on endoscopy have significant changes. This study shows something similar, a different classification of reflux when we look at during an endoscopy. And you can see between the mild version and the severe version, the symptoms here, they look similar, okay? And here's the frequency of those symptoms. So we're talking severity before, now we're talking about frequency. These people have reflux every day, and you can see between the two that have bad findings here and also, normal-looking esophagus, they report pretty similar kind of frequency of heartburn. So I hope you haven't eaten, or maybe you're going to eat later, but this picture doesn't come out so well in the lights here, but this is the ulceration and irritation. This opening here is into the stomach. This is the esophagus here. Here's some small ulcers in the esophagus. The esophagus should look like this, kind of pale color. So what happens when we treat people with reflux? Well, they frequently will recur. So over time, This is the percent of people who are symptom-free. We give them Prilosec, Prevacid, Nexium, any of those brands, any of the strong acid suppressors, and they all most become symptom-free. But over time, once they stop it, they all seem to backpedal over 6 months, and generally in some way they're going to get symptoms again. So it is a chronic disorder. The impact of reflux on quality of life, interestingly enough, reflux ranks up there pretty high. People who have angina or heart pain from cardiac disease probably have the same kind of impact on the quality of life as people who chronically suffer from heartburn. Even people with heart failure do better. So here's a cartoon of the basics of the way your upper GI tract looks. This is the diaphragm here. So your chest is here. The abdomen is here. The stomach is supposed to be below the diaphragm. The esophagus enters through this opening in the diaphragm into the stomach. These are the kind of defects that lead to reflux. Well, first off, the esophagus has to clear things. There's peristalsis, so waves of contractions come through to push acid and food contents down. And some people with certain disorders like scleroderma, which is an autoimmune disease, they don't have a lot of squeeze here, and their esophagus can't clear the acid off, so it tends to stay there and cause injury. There's a sphincter here, all right? I think maybe you all know what a sphincter is. Hopefully we do. It's a muscular ring that contracts to close an opening. There's a valve here or a sphincter here. That sphincter works best when it is at this level because the diaphragm here also pinches, as you can see, it's pinching the stomach here. It's supposed to be pinching the esophagus to a slight degree, and it allows the contraction of the diaphragm to be a barrier to acid and food coming up. So when people get a hiatal hernia, a lot of people I see having endoscopies have a hiatal hernias, and it's hard to explain sometimes, but here's a great way to look at it. The stomach kind of pouches through the diaphragm, okay? So now the sphincter is into the chest, the diaphragm's down here, and there's not a synergistic effect of the two keeping food and acid down. Other things, obviously delayed gastric emptying occurs in certain disorders where food doesn't leave very quickly, and it sits here for long periods of time, it builds up and comes up, but also intra-abdominal pressure. So gaining weight is a common reason for getting reflux, the pressure on the stomach from being overweight and fat, both under the skin but also inside the abdominal cavity, pushes on the stomach and forces acid up. Medications, there are a few here that do it. We'll talk about foods in a little bit, but these are some of them. Theophylline is an asthma medication, anticholinergics not used too often, tricyclic antidepressants, progesterone, calcium channel blockers, which are common blood pressure medication, and diazepam, which is Valium. So complications of reflux, there are the esophagus ones and the ones outside the esophagus. Barrett's esophagus, I'm going to talk about in a little bit more in detail, so we'll come back to that. Adenocarcinoma, that's just the typical cancer of the esophagus related to reflux. Strictures, it's a common thing people come to see me for. As that inflammation that you saw earlier heals, it leaves scar tissue. And as you know, with scars in the rest of your body, it's a tough tissue. It's not as compliant. So as food goes down of different shapes, it can hang up on these scars and cause that symptom of dysphagia where food doesn't go down into the stomach well. Ulceration, you saw that before, ulceration leading to bleeding. Extraesophageal, so outside the esophagus. Asthma, we don't understand it completely, but somehow the acid exposure in the esophagus triggers some nerves in the lining of in the lungs, in the bronchial tubes, and they constrict. It's probably not the main cause of asthma, but it is a contributor. Chronic cough, a very common thing. A lot of pulmonologists battle with, and often we'll see them at some point to discuss whether reflux is a component of that. Laryngitis, dental enamel, we talked about that, vocal cord injuries, and some of these things are pretty extreme. We don't see this too often, which is a narrowing of the trachea. So endoscopy, we do a lot of these to basically look and visualize. It's the gold standard for really seeing if there's esophagitis or that erosiveness, that injury that you saw in the picture before. And the only way to really tell about this precancerous condition called Barrett's esophagus. So this is what a stricture looks like. The stomach is through here. This shelf of tissue here is the result of injury. You can see some redness here and scarring. So as a piece of food, typically a piece of steak or chicken or something comes down, it gets stuck here. Sometimes it goes through. Sometimes 2 in the morning, I'm trying to fish it out of somebody so that they can swallow again. Barrett's esophagus, this one doesn't come out so well either. As you can see, remember we talked about this kind of white-colored lining of the esophagus. You can see these little tongues of kind of red lining, okay? This is what Barrett's esophagus looks like. This lining actually no longer looks like the esophagus. The lining of the esophagus is like skin. It's made to be resistant to mechanical trauma. So it's made of the same kind of cells that make up your fingers or your skin to be resistant to trauma. This lining actually looks a little bit between stomach and intestine, all right? And the esophagus is changing itself to protect itself from the repetitive acid exposure. So it's a pretty intelligent an evolutionary defense against the acid. And this lining turns out to have particular types of cells, just like you have in your stomach and in your small intestine, to protect against acid injury. But what's the problem with Barrett's esophagus? Well, it turns out to be a pre-malignant condition, okay? It's about 30 to 60 times more likely you can get esophageal cancer if you have Barrett's esophagus. And the incidence of adenocarcinoma of the esophagus is one of the most rapidly rising cancers in the United States. On an absolute level, it's not one of the more common cancers. You're not going to see it on the top 10 list yet. But we're seeing a rapid rise, and I think the next slide, or coming up slide, will show that better. The prevalence of Barrett's esophagus increases with the duration of symptoms. So usually I use somewhere, you can see about 10% of people in the 1 to 5 year range. The recommendations are probably somewhere in the 3 to 5 years range of having consistent reflux. Those are people having it more than a couple times a week. That's when we start screening them, but you can see as it gets higher, 20% of people develop Barrett's esophagus. This is these little patches here are actually different locations of cancer in the esophagus. So the frequency, we talked about that, greater than 3 times a week. We start to see a lot more. These are the kind of mild people. These might be the people seeing the primary care physicians, and we're kind of seeing these people here. This is showing you the incidence of cancer, how it's been rising since the 60s. You can see this kind of steep rise here. And probably has a lot to do with the fact that heartburn is becoming much, much more frequent for lots of reasons. Obesity is probably a large percentage of that. Westernized diets, and certainly something we'll talk about in celiac disease, probably the fact that our environments are more sterile than they used to be in the past, and the exposure to bacteria probably helps us to a large degree to protect against certain disorders. So how do we manage reflux? Lifestyle, medications, there's surgery, and there's some new endoscopic techniques. There was a real boom in this in the early 2000s. Some of these procedures haven't really panned out. I'll go through 1 or 2. So the lifestyle modifications, we all like to be able to control something on our own, not have to take medications. But it turns out in studies, people who had chronic reflux who tried to do lifestyle changes, they did okay. They didn't really get complete symptom relief. But these are the things you can do, raising the head of the bed, which gives gravity, on your side when you're sleeping, keeping things down in the stomach. Fat intake, we all know when we eat a heavy meal with, a lot of fat in it, we often don't digest as well. Fat goes through more slowly. Some studies didn't necessarily show that a high-fat diet caused reflux, but I think it does. There are certain foods that trigger it for people, very independent. You don't want to lie down within 3. I tell my patients 4 hours at bedtime because you're losing gravity. If I got big, all this food in your stomach, you lie down and it's going to come back up into the esophagus and irritate it. No smoking. Smoking does as well. Losing weight, avoiding alcohol. That's a big offender as well. Caffeinated, products, coffee, tea, those are big offenders of reflux. Real peppermint, not peppermint flavor. We don't see real peppermint too often anymore, but real peppermint has been shown to lower the sphincter pressure at the bottom of the esophagus. Spicy and tomato-based foods, everybody, sees that. Citrus foods and juices to some degree, and I mentioned alcohol before. So this is the evolution of medications. Antacids came out in the 60s and 70s. And Tums and Rolaids are some of the common ones. Their effects are pretty mild. Prokinetics, these are drugs that increase I showed before that if food stays in your stomach longer, you're more likely to get reflux. These medications help the stomach to empty more quickly. They have side effects. This one was taken off the market a few years ago. And Reglan, you can't use it too often. It has too many side effects. So we're left with this called 2 class here. H2 blockers, which came out in the late 70s, Pepcid, Zantac, Axid, Pepcid Complete, their whole slew of them now. And then the most recent proton pump inhibitors, which Prilosec, Prevacid, Nexium, Asifex, Protonix, I don't want to leave any out, Zegerid, are extremely effective at lowering acids levels in the stomach. Prilosec came out in 1989 and was the first one, so we've had over 20 years of experience with them now. This is kind of a cartoon of what the acid-producing cell in the stomach looks like. It's called the parietal cell. So all these medications are trying to tackle what this cell does. This cell makes hydrogen chloride, which goes into the stomach. Antacids just neutralize it locally, so you're just putting it into the stomach and neutralizing the hydrochloric acid, which turns out to be a pretty weak way to do it. The H2 blockers, that's Pepcid and Zantac, they block histamine. Now, histamine is a hormone in the stomach which actually triggers this receptor here, telling these pumps in here to make hydrogen chloride. So if you block this, you figure, well, you're going to block the acid production. But it turns out that there are other mechanisms by which the cell is stimulated. So they're weak acid suppressors. They're good for the person with occasional heartburn, but not for the chronic acid reflux sufferer. Turns out that the pumps here are the final pathway right here. These are the ones that actually do the actual production. It's a hydrogen potassium pump. And the proton pump inhibitors bind to it and inactivate it permanently. So that in order for for the stomach to make acid, it has to make new cells. It can't make new receptors. It has to make a new cell. So this turns out to be a very effective way to lower acid and control reflux. I was going to just touch on some of the endoscopic procedures. We don't do them here at the Summit Medical Group. There are not many people that are doing a lot of these. They're still investigative stages. There's some more promising ones coming out. This procedure, the Stretta procedure, which I trained in Boston on, came out in around 2000. What we're doing is applying heat to the bottom of the esophagus to cause a thermal injury, which allows the esophagus to remodel and probably create a barrier to acid coming up. It also probably in some way affects the way you feel heartburn. Success rate here was fairly good, 70% at 1 year. There are complications. And for acid reflux, which is generally a benign disorder, having a perforation that's life-threatening, maybe not something you want to submit yourself to. But this is the archaic-looking device. These little probes are released in the esophagus and send a thermal injury. I'm going to show a better picture of that here. Oops. Yeah. And basically, it causes a little burn all along right where this lower esophageal sphincter, and you can see this is the way it should be. There's a diaphragm here, the sphincter's here, and this is what it looks like. Unfortunately, it doesn't look too pretty, but these burns heal to cause some sort of collagen deposition into that sphincter, which gives it a little bit more robust strength, and it has been obviously shown to prevent people from feeling reflux. It is still available in some centers. This is a failure. Anorex was actually approved in 2003. It's a biocompatible, it was a biodegradable polymer that was injected into that sphincter to actually make it thicker to prevent acid from coming up. Had very similar results to the other procedure you saw, but it was recalled in 2005 because of injections outside of the esophagus into the chest, which resulted in severe complications. So my take home on this, something I do a lot of. I don't think a lot of these procedures are ready for prime time yet. There are some new ones coming out, and I think this is probably a wave of the next 20 years. And I think these need to really be fine-tuned a lot better. And for now, I didn't mention it. There are others. One slide I left out was the surgical option, which is called a Nissen fundoplication, where the surgeon actually reduces that hiatal hernia and then uses, see if I can go back, uses this portion of the stomach here to actually wrap around to make basically a high pressure area to prevent food and acid from coming up. Successful at 5 years, probably about 80% of people are without symptoms, has side effects. People sometimes get dysphagia, food can't go down well, they get gas bloat syndrome where they can't belch anymore. So nothing's perfect. Right now the proton pump inhibitor medications seem to be what we're using the most. So that's the end of that talk. I thought perhaps in between talks I'd just take 10 minutes or so just to answer questions on this, and then we'll go on to celiac disease, and I'll leave some answers, time at the end for that. Yes? Prilosec's been around since 1989. We have a lot of data on it, and there's been a lot of news about the fact that we lower the acid so effectively with these medications. Does it have long-term effects? So there's probably two main areas that have been of concern. One is that calcium may be absorbed improperly. We don't understand the exact mechanism. But if calcium's not absorbed over long periods of time, osteoporosis is more common. There have been studies showing hip fractures and being at a higher incidence in people on proton pump inhibitors for over a year. So there isn't a consensus about what to recommend in that situation. In fact, having long-standing reflux, as you know, we talked about, can lead to cancer and other problems. So they're competing problems, you know. The other problem is that low acid in the stomach. What does acid really do in the stomach? It's not needed for digestion, believe it or not. It's probably evolutionarily there to destroy bacteria. We eat things that are, you know, been touched by other people, and animals also have this issue of eating things that are not the cleanest, and the acid neutralizes most of those bacteria, all right? So when we lower that acid, what are the implications? Do people get gastroenteritis more often? Turns out maybe a little bit more, but there's a particular bacteria that we're hearing a lot about in the news that's in hospitals a lot called C. difficile, which causes a very terrible diarrhea, and it appears that it might be a greater incidence of getting that infection. It's also been seen that in the community-acquired pneumonias might be a little bit more, all right? That's not clear. None of these things are absolutely clear. It's thought that acid in the esophagus probably prevents colonization of bacteria in your esophagus, and that bacteria may spill into the trachea and lead to pneumonias. All these things are not exactly clear yet, but those are the concerns that have come up. Yeah, you know, we see a ton of these fundic gland polyps, which are a very benign type of polyp. The data, which again, we have lots of years of having these medications and me sampling these, to be honest with you, I don't think there's any implication from them. Not necessarily. We do a lot of testing before someone goes through the fundoplication, the surgery. People who don't respond to medications typically don't do well with the surgery. So if you're the best person for the surgery is someone who's had a great response to whatever they're on, Prilosec or Omeprazole, and they just don't want to be on a medication the rest of their life, or they're concerned about the side effects of being on those medications long term. Those are the people who do very well. People with some of the symptoms that are really difficult to treat, some of these outside the esophagus, things like coughing and whatnot, they're not the ideal candidate. We do pre-testing to make sure the motility of the esophagus is intact and really confirm the diagnosis with pH testing, which we do. As I mentioned earlier, obesity is probably the number one reason we're seeing an increase in reflux. So, you know, the quantity of food goes just directly to that. But in addition, over-distending the stomach with large meals is going to predispose you to getting reflux just by the pressure placed on that sphincter, which is often weak in people who already have reflux. Like we went through with the foods, particularly there are those specific foods that are more bothersome. People who suffer from reflux certainly keep those to a minimum, including, you know, the common caffeine and alcohol being the big ones I tell my patients. I tell my patients who suffer from reflux that there are not a lot of guidelines. I will say there are sufferers for more than 3 to 5 years. They should have one endoscopy. That's the recommendation. Now, after that, you know, do you do it every 10 years, or as like a colonoscopy? There really aren't guidelines for that. I tell my patients that it's a risk stratification. It's like going on your exercise stress test when you want to make sure you don't have heart disease. It risk stratify people. So it tells us that they're worrisome or not worrisome. So my patient has reflux who has a completely normal endoscopy. I tell them they have heartburn, they have reflux, but they have non-erosive reflux, and that's a good version. And I don't recommend that they routinely have another endoscopy unless something new happens. They get that food's not going down well, or the symptoms become, you know, refractory to medications. You know, those kind of, they're losing weight, or they're having bleeding or anemia, that kind of thing. You know, people who have you know, reflux for more than 10 years, about 21% of them had Barrett's esophagus, and that's the precancerous condition. And then about 1% of them, well, 0.5% of them will go on to cancer per year. So it takes a long time. You know, it's years. It's not something that happens short. That's why we deal with the heart disease now. We'll deal with the heartburn down the line, you know. All right, so I'm going to move on to celiac disease. What is it? Celiac disease is I'm going to use the textbook version there, a genetic disorder characterized by a damaging immune response within the small intestine in response to foods containing gluten. So it's not an allergy. Some people are allergic to gluten. That's a structure of in certain grains. It's not really an allergy. What happens is your immune system responds aberrantly to this and makes antibodies that cross-react with proteins in the small intestine and destroy the villi. Villi are these finger-like projections, I'll show you some of those, that absorb nutrients. These villi are very small and are damaged, not irreversibly, but are damaged enough that it can affect your nutrition and cause malnutrition. All right, so here's some stats. So gluten, a protein found in wheat, rye, and barley traditionally. 1 in 133 people in the United States probably has the disorder. It's about 2 million people. If you have a first-degree relative with it, there's a 1 in 22 chance that you might have it, and a second-degree relative about 1 in 39 risk. It turns out that this varies throughout the world. In Algeria, there happens to be a certain population in a corner of Algeria that has about a 1 in 18 in their general population, 1 in 18. So that's probably the highest incidence we see in the world. It's not seen in the Far East. China and Japan, rarely do we see this. But 1 in 6 Down syndrome patients actually has it. That's an interesting phenomenon. And women more often than men, about 2.5 to 1. So it can be diagnosed at any age. 10 years ago, we were just pretty much looking in kids, and this was a pediatric diagnosis. The people who had it that were adults were diagnosed generally in their early childhood. Now, we're seeing it all over the place. Most commonly in adults, women, it's a little earlier, the 4th decade. Men, probably in the 5th decade, but we're seeing it for the first time in the 60s and 70s as well. This is another little picture of our GI tract. We were up here in the esophagus before, in the stomach. Now we're coming down through the stomach and into all the small intestines. So food comes down, goes through the small intestine, and then out the colon. The area of interest is the small intestine in this disorder. This picture came out okay, but this is the small intestinal lining. We've opened it up on the inside surface of these little finger-like projections with these tall cells on them. It increases the surface area exponentially to allow nutrient absorption. And these little villi are what are damaged during this disorder. Healthy under the microscope, these are the healthy villi sticking up here with the cells lining right here. We call those columnar cells that are engineered to absorb everything we eat. Here is what happens. These little cells here are lymphocytes. They're a type of white blood cell that are reacting to an aberrant immune response, and what they're doing is infiltrating these villi and destroying them. And with the endoscope, this picture didn't come out as good as we actually see it. I say it's they're microscopic. We actually, with an endoscopy, we actually can see them individually now with the high-definition endoscope. So although we biopsy to really confirm the diagnosis, I can often see the villi and know someone doesn't have it, or at least doesn't have a severe version of it. Here you can see it's kind of shaggy, looks furry, because these are the villi on the lining. This is someone who has celiac disease, so there's complete atrophy, the fuzziness is gone. We call this scalloping. You can kind of see it here. When we do an endoscopy, we look for this kind of scalloping on the folds, and everything looks shiny and flat. Symptoms, all right, so symptoms vary. They're really non-specific. So I'm going to go through them today, and people here who don't have celiac disease are going to start to think they have celiac disease, just because they're very, very non-specific. And we're seeing now more and more people have absolutely no symptoms, which is a real challenge for treatment, because you're going to go on a diet, and if you have no symptoms, why do I want to be on such a terrible diet? So the symptoms that are common to kids and adults: bloating, abdominal discomfort, vomiting, here we go, diarrhea and constipation. I mean, how varied can it be? Weight loss is that's one of the more universal ones. Fatty stools from malabsorbing fats. Children, delayed growth is a big one. Short stature, pediatricians are looking out for that. This failure to grow, this is one of the first things they'll start thinking about. Irritability, I have 2 kids, I don't know whose kids aren't irritable. Delayed puberty, and this, gosh, the dentists keep getting in here again. Here we got the dental enamel thing again. So adults, fatigue, that's pretty common, huh? Iron deficiency, that's one I see a lot of. A lot of patients refer to me because they're iron deficient, and the absorption of iron happens to take place in one of the most common places for these villi to atrophy, which is the beginning of the intestine called the duodenum. So iron deficiency is a pretty common one that I see. Osteoporosis, we were just talking about that, related to the reflux medications. Calcium absorption is impaired. Osteoarthritis is probably a relation to that. Missed menstrual periods is probably because of malnutrition. Women who are malnourished tend to stop having menstrual periods. Infertility follows that same, miscarriages, all these things. Depression, and then this itchy rash we call dermatitis herpetiformis, which I have a picture of. It looks like a vesicle. This is a little blistering lesion. It's very intensely itchy. And it turns out that even people who don't have the GI symptoms of celiac disease, if you show up with this and the biopsy shows the findings, somewhere between 85 and 100% of people also have celiac disease. So I said before, it's an autoimmune disease. So your body is being triggered to make antibodies against itself, all right? So there are other diseases associated, so other autoimmune diseases. Thyroid disease is often autoimmune. You make antibodies against the thyroid cells. Liver disease, we see. Type 1 diabetes, that's an autoimmune disease. Antibodies against the islet cells in the pancreas. Rheumatoid arthritis, Addison's disease, and Sjogren's. These are all autoimmune disorders seen in increased incidence with celiac disease. So how do we make the diagnosis? Well, there are really good blood tests for it. Any of these are very sensitive and pretty specific. This is the one most well-known and used commercially. It's the least expensive. It's 96% sensitive. It targets, turns out the antibody that probably destroys these villi is targeting this enzyme within that cell called tissue transglutaminase. And the anti-endomysial antibody is somewhat related to that, and gluten is also another autoantibody. There are ways to genetically test it, okay? HLA is a particular type of antigen-presenting white blood cell. It's a genetic characteristic of white blood cells. Turns out these particular types of genetic antigens, DQ2 and DQ8, are almost seen virtually in everybody who has celiac disease. So this is useful. It's useful for excluding the diagnosis. It's very specific. So if someone comes to me who says, I have celiac disease, I know I have it, I eat wheat and I get sick, and I tell them, well, I'm not sure you have celiac disease. It turns out that if you're on a really strict gluten-free diet, these go back to normal, okay, because the antibodies diminish. So if I test your blood for tissue transglutaminase and you're doing a really good diet, it'll probably be normal. So that just means you're doing a good diet. It doesn't tell me whether you have celiac disease. So what I will do in that situation is, I offer them to go off the gluten for 2 weeks, and we can do the antibody test or an endoscopy. Most people don't want to do that. So this is a good way to look, because if I happen to send these two off and they're negative, then it's virtually impossible that they have celiac disease. Often they don't want to hear that, but it does help me to let them know whether I really think they have it or not. Endoscopy with a biopsy of that small intestine, your shaggy small intestine we saw before, that's really the way gold standard for diagnosing it, although the blood tests are very good. So what are the causes? Well, I don't have a lot here because we don't know a lot. We don't know why. We're seeing it a lot more frequently now. We're also seeing it more in adults. Question is it being seen in adults because we're looking for it more, or is it actually presenting later in life? And I think the answer is both. I think it's both. We're looking for it more, but I think we're seeing it more often in adults than we did with children. And environmental issues seem to be right at the cornerstone of this. We'll talk about the infant feeding. There's a lot of when do we introduce gluten into the diet, and how does that affect the way a child's immune system develops tolerance to gluten? That's a very essential part of looking at these environmental causes. There was a Swedish study that looked at in Sweden there was an epidemic of celiac disease in kids between about the mid-'80s to the mid-'90s, and they went back and looked at why did that happen. And when they looked back in the cohort of kids, it turned out that around that same time, the infant formula foods in Sweden for whatever reason, a large amount of gluten was introduced into infant feedings. And it turned out also that around 6 months, the pediatricians were recommending switching abruptly to infant feeding from breastfeeding. And it's thought somehow that breastfeeding probably offers some sort of tolerance to gluten. And the fact that they abruptly started it and then were introduced to gluten probably set the immune system off and dysregulated it. But it's not clear exactly. Infection, I'm going to talk about this a little bit more later, but we're exposed to lots of bacteria and parasites. In the Western world, we aren't. And our immune system is very much molded by the experience that it sees of bacteria and viruses and parasites. And the fact that we don't see them anymore probably leaves our immune systems just off a little bit, off enough that they misinterpret proteins and things that we eat, and probably sets off a cascade of all of these autoimmune diseases that we're seeing, a lot of these autoimmune diseases that we're seeing. Socioeconomic issues. Turns out that in poorer third world nations, we see less celiac disease than we do in Western world. It probably has a lot to do with both of these factors impacting here. Genetics, we talked about these two particular genetic defects. There are some of these that are not related to these particular antigens. Those haven't yet been completely delineated, but there are probably multiple of them. So what's the treatment? Well, the cornerstone is a gluten-free diet, all right? Improvement is often seen symptomatically in days. People often feel a little better. The small intestine takes a while to actually heal completely, probably 3 to 6 months. The villi do return to normal. This isn't a permanent defect. They can start absorbing nutrients as they did before. You have to be pretty strict. Even small amounts of gluten have been shown to trigger this autoimmune response and damage the villi. So much so that in 2004, the Food Allergen Labeling and Consumer Protection Act was passed, which in 2006 went into enforcement, which meant that in the back of every label, anything that is a wheat product needs to say it's wheat. But unfortunately, as I mentioned earlier, barley and rye are also offenders of causing celiac disease and aren't part of this legislation. So people who are celiac sufferers have to really be looking at the back of those cans and those jars. So what are the foods to avoid? Well, wheat, we talked about that, comes in different names, different types, Emer, Kamut, Spelt. You really have to become a real, I guess I said, a real label viewer of everything you eat. Barley, beer, rye, triticale, which is a combination of wheat and rye. All these things have gluten in them. Other wheat products to avoid: wheat flour, brominated flour, durum flour, enriched flour. The flours keep going. Farina, semolina, malt. Corn is okay, so malt made from corn is okay. Processed foods, that's a real problem because once something's been processed, it's been exposed to multiple things through the process, and little bits of gluten can sneak into foods, whether they're coatings on the food or mixed with oils that were processed with things that had wheat in them. You can see a whole slew of them here, even communion wafers, matzah. There's no religious exemption here. French fries, potatoes are gluten-free, so why are French fries on the list? Well, it turns out that most French fries are, particularly in fast food restaurants, are made in oil that's probably cross-contaminated with other things, like chicken that has breading on it. And the French fries themselves in the processing are often coated with things, seasonings that have gluten in them. So it's very difficult to tell whether something is just a potato that's been fried. McDonald's claims that they're gluten-free. Apparently, it appears that is true. So if you're going to eat a French fry, McDonald's seems to be all right. What else here? Medications. Well, you think those wouldn't have gluten in them, but some of them are processed with wheat products. They're coated with things that have wheat or gluten or barley or rye. You got to ask your pharmacist. I don't even know all of them. You really got to do your due diligence. Dietary supplements, they can be coated and processed. There are gluten-free vitamins and minerals. There are a couple companies here that make gluten-free vitamins. You need to look for, enriching things, because what happens when we take out a lot of the foods that we eat with gluten in them, we end up with vitamin deficiencies. Vitamin Bs and iron are often missing. Whole grain, gluten-free things, products, enriched products. We need to find the gluten-free things that are actually enriched to give us some of these extra vitamins. All right, things that are allowed. So, meat, fish, rice, fruits, vegetables. Here's a good one: distilled alcohol. Thank God, Scotch is made in barley. It turns out the distilling process destroys gluten. So go out, you're okay with that. Beer, that's a problem. There are beers made out of sorghum. I think barge is what it's called. That's actually some sort of herb, and that's okay. A whole slew of other different types of grains that are right, corn being a big one. Buckwheat, despite saying wheat is okay to eat. Oats is a big controversy. There's initially thought that that oats may have some gluten in it. It's pretty well thought now that small amounts of oats are okay. We talked about potatoes a minute ago, and sorghum, which can be made into beer. All right, so now we're heading towards, well, it kind of stinks to do that diet. So what can we do to fix this problem? Well, there are lots of people looking at it because there's lots of people who have this. So why can't we make a binder or a neutralizer so that just like people who have lactose intolerance have lactate, it's an enzyme to help break down the lactose. Why can't we have foods that you take a pill and it breaks the gluten down so you don't get the reaction? Well, that seems like a great idea. They're looking at that. Neutralizers, enzymatic degraders. This is kind of technical, but zonulin, it turns out that those cells that I showed you on the villi that absorb nutrients are bound together and they have this glue between them, basically. We call them tight junctions. And it looks like gluten, for some reason, makes those junctions weaker and allows the gluten to sneak through and probably trigger the immune response. So people are looking at medications that might tighten up those tight junctions to make the effects of gluten less once it's been eaten. And immune modulators. Well, we talked about this antibody to tissue transglutaminase, which destroys that small intestinal cell. Well, we can make antibodies against the antibodies to kind of just neutralize its effect. So people are looking at that. This is really interesting. What about hookworms? Why would I want to take a hookworm? Well, we talked about the fact that people's immunity has a lot to do with the things they've been exposed to. And it turns out that really parasites, believe it or not, parasites have, over billions of years or millions of years, developed a way to evade our immune system. That's why they can sit there and hookworms live in the small intestine, and they don't want to kill their host. They want to keep them alive because they want to reproduce. So how do they evade the immune system? Well, it turns out they do something to alter the immune system and make it more tolerant to them. So it's being looked at, and it looks sort of promising, although I think most people won't eat a hookworm, but I think we need to distill exactly what the hookworm does. But that tolerance that the hookworm induces in the small intestine may actually cause a tolerance to gluten. So the immune system kind of settles down and doesn't create these antibodies against your own small intestine. All right, so cancer risk. I get asked that all the time because, if I am diagnosed with celiac disease, my mom had it, I feel fine, but I decided, maybe I want to know about this, and I have the celiac test, and I'm confirmed to have celiac disease. But I don't have diarrhea, I don't have constipation, I don't have any of these things. I feel great. So why do I want to do this restrictive diet? It turns out, there is an increased risk of cancer with celiac disease. Probably a modest risk in overall cancer, although this is debated, about 1.3 times the average person. It's probably the risk even in patients without symptoms. The gluten-free diet appears to really decrease that risk. And just through this is interesting, it looks like actually breast cancer risks are a little less with celiac disease, and that's not well understood. But this is the big problem, lymphoma. These are a certain type of lymphoma here, and it's about 16-fold greater in celiac patients than the general population. Here we go with these kind of nonspecific symptoms, but lymphoma can present with weight loss, abdominal pain, fever, night sweats. Turns out to be a pretty dismal cancer with only a 10 to 20% 5-year survival because there are really poor treatments. Complications ensue, including intestinal perforation. And it's hard to treat these patients because they already have a really poor nutritional status to start with. So getting a cancer and being already malnourished is extremely difficult. I left here at the end, and I think there's some copies out there. Today there's lots of resources on the internet. I'm sure anyone in the room who has celiac disease has sat on a computer for a long period of time and gone through some of these. I left a few here that I thought were helpful. So I'm going to open it up a second time for questions. I tell my patients who are on chronic proton pump inhibitors to take calcium supplementation. I tell them between 1,200 and 1,500 milligrams a day with vitamin D. However, if you're concerned, the best thing to do is get a DEXA scan. Find out what your baseline is and follow it. So, yeah, well, osteoporosis is a common problem, but if it's really an issue, certainly can be treated. But you can also come up, it's that competing interest of I feel miserable with my reflux. I don't want to have complications from that, yet I have osteoporosis. It's a difficult question. There's not a real perfect answer to it. A perfect answer is a new medication that doesn't do any of those things. There's a class of medications that were originally used in patients who had, for example, cerebral palsy to get rid of spasticity. They work on a receptor that relaxes muscles. It turns out that at the sphincter there, you get the opposite effect, that it actually tightens the sphincter up. They have side effects. They're looking at new versions of them without those they cause all sorts of central nervous system side effects. They're trying to isolate out a compound, and that looks like where things are going. So there's a whole bunch of studies I've seen recently looking into that. That might be the next wave. You don't outgrow it. But fortunately for her, she was diagnosed early, which is a wonderful thing. And thankfully, over the last decade, the amount of foods available for someone who has celiac disease has exploded. There's so many better options than there was 10 years ago, where patients were limited to a few stores and a few places. Now you can buy things on the internet. Whole Foods has a whole gluten section, so you can live a reasonably normal life, not having going out and doing what you want. So I think it's just fortunate she was diagnosed early. I biopsy. All right, so that's a good question. I biopsy. Remember, you saw those little tongues of lining that was a different color. That's what I target. I target those. Okay. I don't randomly biopsying is not a good idea. It turns out that these cells that look like the small intestine probably normally live right at the junction between the esophagus and the stomach, a very thin, several millimeters area. So if every person with reflux, so I look at it, it looks totally normal. If I biopsy them, I might find this Barrett's, technically, these cells that look like Barrett's esophagus, but they don't actually have it because it's normal. And people don't have reflux, you're supposed to have a little bit of it there. So what we try to do is we target the biopsies. And then there's a protocol for how, for example, if someone has 6 centimeters of Barrett, those tongues go 6 centimeters up the esophagus, we take biopsies in 4 quadrants every 2 centimeters all the way up. That's kind of the protocol that we use. In patients who have worse and precancerous changes, we start to do them at every 1 centimeter interval. So they're really targeted. It's basically, we used to do pH testing by putting a catheter in your nose, and you'd swallow it, and then you'd wear this little device, and you'd go home with it sticking out your nose. And the device would measure the acid in your esophagus for 24 hours, and you'd come back the next day and we'd pull the tube out of your nose and we'd read how much acid was in your esophagus. People didn't like that very much, as you could imagine. So Bravo is made by Medtronic, I think. It's basically a small device. It's probably the size of the end of my nail, and it has basically we suction cup it onto your esophagus. We do an endoscopy. The device actually uses pressure to suck a little bit of tissue into this little device. So it suction cups onto the wall, and then we leave it there. And it sits there, and you wear like a BlackBerry device, and it wirelessly sends all the pH data back, and that device falls off somewhere in the 2 to 5 day period. And then, you don't collect it. It's disposable, so you just flush that down. And we use the data to really confirm whether someone has reflux or whether they're actually responding to treatment. So we use it before doing fundoplications to really confirm that people have acid exposure before the surgery. It is well tolerated. Sometimes people feel a little chest discomfort from it. Some people feel like food's not going down right. But in my experience, it's pretty small, and it's a great alternative for pH testing. Plavix, it's a powerful anti-platelet drug, so it's used in patients who have cardiac stents to prevent those stents from getting clots in them, and it's a very widely used medication now. And it makes me worried to biopsy when someone's on that. So usually I check with the cardiologist. The bigger question is whether those medications, and this has been in the news a lot, whether proton pump inhibitors, Prilosec and such, interact with Plavix and neutralize its effect. And there's a whole controversy about whether or not people on Plavix can be on those medications. And they have been frequently used hand in hand because Plavix can cause gastrointestinal bleeding from ulcers. So people will frequently put on those medications to prevent ulcers and esophagitis that might bleed on Plavix. And there's some evidence, and there's a lot of battle between the gastroenterologist and the cardiologist, whether the Plavix interaction with proton pump inhibitors is real, but it's been in the news quite a bit.